patient.
Okay, guys, you have a couple different devices that we actually use. These are kind of the main ones that we use for delivering oxygen to our patients, depending on how much oxygen we need to deliver to our patients and how critical our patients are. So we're going to go over the non-rebreather masks, the bag valve masks, and the nasal cannulas. So when we're talking about non-rebreather masks, it is the preferred way for us in the pre-hospital setting to actually give oxygen to our patients. When we are using a non-rebreather mask, we're giving anywhere between 10 and 15 liters of oxygen per minute. With the non-rebreather mask, as you can see on the picture, it is a mask that will actually cover the nose and the mouth, and it has that little bag on the bottom. There is also a filter that kind of covers the entrance to that bag. It's a very small filter. It is HEPA compliant, and we do need to make sure that the actual bag fills up with oxygen when we put it on somebody's face. The bag itself can hold quite a bit of oxygen for us. So it does give us kind of a little bit of a reservoir just in case we do, for whatever reason, run out of oxygen during the time that we are giving oxygen to the patient. But we do need to make sure that bag's filled up. And what you do when you guys see the mask, and you guys will get this mask eventually at some point in all of your kits that you're getting from school, you'll see the little filter, and you literally just kind of cover the opening of the bag in order for the bag to fill up, and then you let it go and the bag is filled. Okay. These are basically for patients that are going to have low O2 saturations, could also have possibly high end-tidal CO2 readings. But basically, these patients are breathing adequately. However, we're still suspecting some kind of hypoxia. So maybe somebody with pale, cool, clammy skin, or like I said, low readings on the pulse ox. Maybe they're cyanotic, or high readings on the end-tidal CO2. So like I said before, we do want to make sure that the reservoir bag is full before placing the mask on the patient. That way we know that we are delivering an adequate amount of oxygen, or what we believe, based on the actual standards of the industry, anywhere between 10 and 15 liters per minute for the non-rebreather mask. We want to make sure that we're actually filling up that oxygen reservoir in order to give the amount of oxygen that we are desiring to our patients. We can remove it, right? If our patient starts to get better, we're starting to see improvements in skin color. We're starting to see improvements in the end-tidal CO2 is starting to lower a little bit, or our pulse ox is coming back up to that normal range. And remember, we're trying to get that pulse ox anywhere between 94% or higher, not necessarily at 100%. Okay. But this is something that we can remove, and just because you started a patient on one oxygen delivery device doesn't mean you can't change it. Okay. What we won't do, all right, is if they are a non-rebreather mask, we're not going to put them down to anything below 10 liters per minute. We're actually going to switch devices in order to deliver oxygen, less oxygen to the patient, and we'll talk about that when we get to that specific piece of equipment. Nasal cannulas are actually a smaller device that we use to deliver oxygen. Usually these are anywhere between 1 and 6 liters per minute. So this would be something that you're actually downgrading from the non-rebreather if you needed to for your patient, once we kind of get our patient stabilized. So it does deliver oxygen through two small tube-like prongs that actually fits in the nostrils of the patient, and then we kind of wrap the tubing kind of behind their ears and tighten it up right around their neck. Obviously not choking them, right, but enough so that it doesn't fall out of place. This usually is providing anywhere between 24 and 44% of oxygen when you actually have that flow meter on your oxygen tank switched anywhere between 1 and 6 liters per minute. All right. The other thing I want you guys to keep in mind is that we don't necessarily have to put these in people's noses. If we have somebody that maybe has some kind of trauma to their nose, or they just sound kind of stuffy, maybe they got some kind of sinus infection going on, or maybe they've had some kind of medical problem where they've kind of turned into mouth breathers, we can also put these prongs kind of in their mouth excuse me, put these prongs in their mouth in order for them to get that 24 to 44% of inspired oxygen. When we are using nasal cannulas, we can actually hook up any of our devices, the nasal cannula, the non-rebreather, or even the BVM, to humidified oxygen. And each service does carry some form of humidified oxygen that we can use for our patients. And we do want to maybe think about that when we have really long transport times. Now, us here in Bernalillo County, we really don't have those longer transport times to where we really need to keep the patient on humidified oxygen. But if we're doing like an out-of-state transfer and this patient needs to be on oxygen during the whole time, we might want to use some humidified oxygen, because we are drying up their sinuses when we have this constant flow of oxygen going straight into their nasal cannula or nasal pharynx. Okay. Again, a patient who has or mouth breathers who has some kind of nasal obstruction can benefit, but we are putting this in the mouth. If we do have to think about putting the nasal cannula in the mouth, it might be beneficial to just put them on the non-rebreather instead. And then if we need to give that high flow oxygen, we need to make sure that we are using a non-rebreather mask instead of the nasal cannula. Okay, guys, I did skip ahead. You guys can read on the other masks that you may see out in the field. We don't carry those typical masks on the trucks. These are something that you might see as far as transferring patients from one place to another. However, we are going to talk about assisted and artificial ventilation, and this is by far the most important skill that you guys are going to learn. And this is the most important skill that I'm going to harp on you guys to make sure that you're doing it correctly. Basic airway and ventilation techniques are extremely effective for our patients. And we need to make sure that we are monitoring the patient's airway at all times while we're delivering these breaths through the bag valve mask in order to not cause any more damage to our patients. Because if we are inappropriately bagging our patient, okay, if we are squeezing that bag too hard, if we're squeezing that bag too soft, first of all, if we're squeezing too soft, we're not giving the oxygen to the patient. If we're squeezing too hard, we can actually cause some kind of barrel trauma. We can actually pop a lung and cause further damage to our patients. We do have these tools in order for us to intervene quickly to prevent deterioration of our patients. This is going to be somebody that is in severe respiratory distress. Either they are not breathing at all and they're already in respiratory arrest, or this patient has been breathing so fast for so long that they're actually getting tired of breathing, where we can actually assist them with their respirations. And we do have two different devices that we're going to cover at the basic level. We have the device known as the BVM, which I believe we're going to talk about here in a sec, and then we're going to have a whole recording on just the CPAP. CPAP stands for Continuous Positive Airway Pressure, and it's actually a machine that we use to kind of help the patient breathe, take that nice deep breath in, so we have that adequate tidal volume, so that we have that good adequate chest rise. And there are some things with the CPAP that we do need to discuss, but we'll do that here in a minute. There are some contraindications to it, but we need to make sure that we are providing good oxygen therapy specifically for anybody in respiratory distress or respiratory failure. Okay, so some signs and symptoms of where we need to kind of put on our back burner or into our thought process of this patient might be going into some kind of respiratory distress or failure. I know we've talked about this a little bit already in our patient assessment for the respiratory system. But altermentation, right? Any altermentation, we need to start thinking about maybe this patient is hypoxic, and that's the reason why they are altered. Their brain is not getting enough oxygen, and the brain is kind of starting to become irritated. If we have an inadequate minute volume, again, minute volume is your respiratory rate times your tidal volume, okay? So if our respiratory rate's too fast, more than likely our patient's probably breathing a little shallow, and we need to make sure that that patient stops breathing shallow in order to slow down their respiratory rate. Our patient might not be breathing at all, right? And we need to actually breathe for our patients in order to keep perfusing the brain. Or if they're just getting tired of breathing, or they're really using every single accessory muscle that they could, such as their intercostals, they're starting to head bob. We're really starting to see them kind of strain their neck. or if they're actually belly breathing, that would be times when we would start thinking about, hey, we need to step this up a little bit. We need to either start to bag the patient or place this patient on the CPAP. Okay, so if your patient is alert and you guys do have to actually assist them with bagging, this is a skill that's going to take a while for you guys to actually learn. And you guys will never be able to learn this actually in class. This is something that's going to come with experience. It's very hard to convince somebody who is short of breath that you're going to put a mask over their airway. You're going to hold this mask tightly to their face, and you are going to breathe with them as they breathe in. So you're really going to have to be in tune with your patient. You're really going to have to be able to watch their chest rise so that you can deliver the breath as the patient needs it. Okay. It's very easy to do when somebody is unconscious, right? When somebody is unresponsive, they're not awake, they might not be breathing, or they might not be breathing sufficiently enough, such as if we're dealing with somebody with like an opiate drug overdose or something like that. But we're going to make sure that we are placing the mask over their mouth and nose, and we want to make sure that we have a good seal. So you guys are going to have to press down that mask a little bit. We're going to talk more about it when we actually get the equipment. When you guys are doing your progressive airway scenario, please make sure you guys are starting to watch those skills videos in your lab shell. We're going to squeeze the bag each time the patient breathes. So we have to be in tune with our patient. We have to be kind of watching our patient and watching when they are actually starting to the process of inhalation. We are going to deliver an adequate tidal volume, so we want to make sure that we're looking for that chest rise. We want to squeeze that bag as they are breathing in, and we want to kind of stop when we see that they are ready to exhale. And we want to make sure that we are maintaining a good seal and maintaining a good adequate tidal volume or minute volume. So we want to breathe or try to breathe anywhere between 12 and 20 breaths per minute, even if they're breathing 30 times a minute, right? So before we would go to this step, we would try to coach our patient's breathing down, which means you'd get in front of them, you'd make eye contact, and you're going to coach the patient breathe. They're going to watch you breathe, and they're going to try to replicate what you guys are doing, all right? Again, this is very hard to do on somebody that is awake, and I think the CPAP is much more appropriate now that we do have it in the basic level to help these patients out. Okay, so let's say your patient is not breathing, okay? That we want to make sure that our airway is open and patent. We talked about that already in another lecture. And then we want to really start getting on oxygen delivery, okay? There might be times where we don't know how long this patient has been without oxygen. Oxygen is top priority at this time, okay? If we have somebody that's unresponsive, we need to start delivering oxygen first, but we need to make sure that that airway is clear. If that airway has any blood or teeth or foreign body obstructions or possibly even just the tongue is occluding the airway, or vomit, if we decide to actually bag the patient without checking that airway first, there is a good possibility that if that airway is filled with vomit, that when we deliver that first breath, we're going to shoot that vomit straight into their lungs. We have just caused a aspirated pneumonia onto our patients, and more than likely we're going to have some very serious detrimental effects for them. So we want to make sure that our airway is clear, okay? There are some different techniques with BVM. Mouth to mask. Mouth to mask is basically what you guys are going to learn in Health 1001. We do not do that in the field. With all the equipment that we do have, it is much easier for us to actually use the BVM. You guys can use the BVM by yourself as one person BVM. We prefer two person BVM, one person to kind of hold the mask to the face and make sure that we have a good seal, and the other person squeezing the bag. We are going to teach you guys one person's BVM skills in this class, just in case you guys are by yourself one day and you guys need to bag a patient. Okay, guys, I did skip one slide number 6, in assisted and artificial ventilation, because it's basically a repeat of what we already talked about in the patient assessment. When we talk about positive pressure ventilation, or how we label that as PPV, we are talking about BVM. We are bagging our bag. We're using a bag valve mask (BVM) in order to deliver adequate oxygenation to our patients. If we are doing it correctly, okay, none of this applies. If we are doing this incorrectly, we can actually increase the interthoracic pressure in our chest, and we are not letting the blood actually return to the heart appropriately, okay? So specifically, if we are not giving time to let the actual lungs deflate, and we keep them inflated because we're bagging too fast for our patients, we're actually putting pressure on the superior and inferior vena cavas, and we're actually starting to squeeze them, so we're not able to get the blood back to the heart like we should be. So we need to make sure that we are breathing 1 second in, 5 to 6 seconds out. 1 second in, 5 to 6 seconds out. That's how you guys are going to be trained on using your BVM. The other thing is that if we are breathing too fast for our patients, and we're not paying attention to good, adequate chest rise, we can be forcing air into the stomach. And if we start hyperinflating the stomach with air, eventually that patient needs to expel that air out of their stomach, which means more than likely they are also going to vomit. So we need to make sure that we do have good control of our airway, that we are doing good, adequate BVM skills, that we're not breathing too fast, we're not giving them what we call the hurricane of death. We're not squeezing that bag too hard. We just want to squeeze that bag just enough in order to see that good, adequate, gentle chest rise. And remember, when we see that good, adequate, gentle chest rise, we know we are delivering the appropriate tidal volume to our patient. We know that those lungs are inflating to the point where they need to inflate in order to create that pressure gradient, in order to help diffusion of the oxygen and CO2 throughout the body. We are going to cover mouth-to-mouth and mouth-to-mask ventilations. We're not going to practice it in class, but we are going to talk about it because these are still skills that are used in EMS. Now, that being said, the only people I would do mouth-to-mouth with are my loved ones if I didn't have a mouth-to-mask barrier, okay? My family, my direct family, maybe some of my close friends if I needed to, right? But it's not like I'm going to take the average patient off the street and start making out with them to try to save their lives, right? And that includes even the mouth-to-mask. You guys will be practicing mouth-to-mask ventilations with in your Health 1001 when you guys are doing CPR. If you guys have already taken the class, you guys know what this is like already, okay? I don't want to be anywhere near the patient's airway, specifically when that patient vomits, right? Or if they have blood in that airway and they happen to cough. Last thing you guys want to do is be sprayed with the mist of blood from somebody, because you guys will have to report that. You guys are going to have to report that with your infectious control department, and more than likely you guys are going to be put on antibiotics as precautionary measures. And you guys could be on antibiotics for quite some time, to be honest with you, until they actually figure out what kind of disease processes the patients have, okay? And then there's routine checkups that you guys have to go through. It's just something you guys don't want to deal with. So make sure that you guys are wearing the appropriate PPE. Anytime that you guys are dealing with the airway, you guys should be wearing your goggles, and you guys probably should be wearing a mask over your nose and mouth while you're doing this, just in case that patient does end up vomiting. And it does happen, guys, right? It's happened to me. I've been in EMS a long time. I've been sprayed with vomit and blood numerous times, okay? But I've always been wearing the appropriate equipment when and if that happens. So make sure that you guys are wearing the appropriate PPE if it comes down to the point where you guys need to start bagging or assisting the patient with their respirations. Again, we are covering mouth-to-mouth and mouth-to-mask, and I'm not going to spend too much time on it. Basically, this is all I'm going to say about it. You might see some questions on it with the National Registry, but really what this all comes down to is just making sure that you guys are doing the appropriate airway precautions, making sure that your airway is open and patent, whether you're using the head tilt chin lift, jaw thrust maneuver, whether you're dropping an NPA, which is that nasopharyngeal airway, or the OPA, which is the oropharyngeal airway, or even if you guys are dropping the King supraglottic airway or the laryngeal mask airway, the LMA supraglottic airway, please, please, please make sure that you guys are getting a good seal. Make sure you guys are wearing the appropriate PPE for the situation. So how do we know that we are actually getting adequate ventilations? The skin color of your patient might improve. Okay, we might actually start seeing the adequate gas exchange because we are breathing at a rate between 12 and 20 breaths per minute, because we are squeezing that bag just enough to see that adequate chest rise. So we know we're getting that good chest expansion. We can see improvements in our oxygen saturations for our patients. We can see improvements in our end tidal. And I know we haven't covered too much on end tidal yet, but we will, trust me. On our end tidal CO2 readings, we're not getting any kind of resistance when we're bagging, right? That air just kind of, you're not having to fight to squeeze the bag. You just can nice and gently kind of squeeze that bag without any resistance whatsoever. And you can actually kind of hear the air escape when the patient exhales, right? And even if you are kind of truly getting a good seal with inspiration on that mask, you'll still hear a little bit of air leakage once that patient does exhale, whether they're unresponsive or not, guys, okay? Remember, when that diaphragm contracts, it pushes down all those abdominal organs so that we can get that good chest rise. And we are forcing that diaphragm to do that when we have somebody that's unresponsive and we are squeezing that bag, right? So that we get that adequate chest rise. And when that diaphragm relaxes, remember that that diaphragm is technically pushing the air out of our lungs, right? So we can actually hear the patient exhale while we are delivering breaths to the patient. So our BVM, or bag valve mask, this is what it looks like. You guys can see the actual mask, the part that you squeeze, and it does also have a little oxygen reservoir on the end, and there is a place next to that bag. If you guys can see that little green kind of stem there, that's actually the oxygen tubing and where it actually hooks up to the BVM. Unlike the non-rebreather, we do not have to have that bag inflate. That's more of a hospital thing, a anesthesiologist thing, depending on how much oxygen they want to give. And really, most of our BVMs don't even have that bag attached to it out in the field. So we do not need to have that bag inflate. If we do have the bag, sure, you guys can inflate it. It's really not necessary when you guys are out in the field. But this is the best way to give a lot of oxygen, 100% oxygen to our patient in their time of need. It is a very common method of ventilating a patient, especially if they are unresponsive. It's the only way we can get our patient to ventilate. It provides a little less tidal volume than our actual mouth-to-mouth or a mouth-to-mask. That's why it's good. We can actually really focus on the chest while we are bagging in order to see that chest rise, where it's a little bit harder to focus on the chest with mouth-to-mouth or mouth-to-mask. And this is going to take some time for you guys to get used to, okay? This is a very delicate procedure. This is a very important procedure, and this is a procedure that you can cause massive amounts of harm to your patient, specifically if you don't know how to do it correctly. If at any point where you guys are starting to get some kind of difficulty with ventilating, whether you guys are starting to get tired, we need to switch providers. If we are starting to feel resistance, we need to recheck the airway. That includes making sure that we are checking for lung sounds as well to make sure that we haven't blown a lung in our patient. All right, or we might just have to simply move to a different method, whether it's downgrading to a non-rebreather or upgrading to actually dropping a supraglottic airway, such as your King or LMAs, or even possibly if the patient is starting to wake up and they are starting to have their own respiratory drive, and you don't feel the need of actually having to sit there and try to assist the patient with their own respiratory drive with the BVM, we can switch over to the CPAP. And really remember, with any of these devices, the volume of oxygen is based on observing that rise and fall of the chest. If we are seeing that rise and fall of the chest with the BVM, that patient is getting 100% oxygen to them. Okay, and whenever possible, whenever you guys have an extra set of hands, you guys should be doing the two-man BVM technique, where one person is really sitting there and just holding the seal on the patient, so you guys get that good seal, and then the other one is squeezing the bag. At any time when you guys are on scene, at any time when you guys are working a code, which is when the patient is pulseless and apneic, when you guys are actually doing CPR, there should be nobody sitting there standing around. It's a little different nowadays because we have the machine that does CPR for us, but there's always something for somebody to do. Okay, when we talk about gastric distension is inevitable when you guys are bagging, specifically when you guys are bagging for a very long time. You guys can have the appropriate seal. You guys can be doing a two-man BVM or even a good, solid one-man BVM. You guys are squeezing that bag just enough to see that chest rise. You're doing one breath every 5 to 6 seconds, maintaining a ventilatory rate of 12 to 20 breaths per minute. And eventually, we're going to start filling up the stomach with air, okay? We can get there much faster if you guys are not doing adequate bagging techniques for your patients, right? It is very common in children, okay? It is very hard to bag a child to begin with. It can be done, and they really respond very well to BVM. So really, when you guys are bagging a child, unless their heart isn't pumping, unless you guys are doing CPR, you're not bagging a kid very long, all right? It's very likely to occur when you guys are breathing too fast or breathing too forceful, and it can also occur if you guys did not check the airway and the airway is actually obstructed. Specifically, if we haven't moved that tongue out of the way and we are trying to ventilate around the tongue, that tongue is going to start kind of moving that air down to the esophagus, and we're not actually getting the air into the lungs. All right, so how do we prevent it? We want to make sure that we have a good positioning of our patient's airway, whether we're using the head tilt chin lift or a jaw thrust. If that doesn't work, then we might need to start thinking about dropping some kind of NPA and OPA. And of course, if that doesn't work, then we need to start thinking about possibly moving to something a little more aggressive, such as one of your supraglottic airways. We need to make sure that we're ventilating at the appropriate rate and that we are seeing good, adequate chest rise, and only good, adequate chest rise for the appropriate volume that we need for our patients. If your stomach does start seeming to become extended, and it looks like it's kind of getting fatter and fatter and fatter, we need to reposition, recheck the airway, do something different, right? The definition of insanity is doing the same thing over and over again without making any change and expecting a different result, right? So we need to make sure that we are doing something in order to reevaluate our situation for our patients. Guys, as you can see, I did skip ahead a couple of slides. You guys can read over slides, 14 through 17. 14 through 17 covers manually triggered ventilation devices, and you guys technically do not have any manually triggered ventilation devices. This is somebody that is actually on a vent, and the actual machine is breathing for them. I will say that you guys at the basic level have no business whatsoever even touching these machines, and it's no offense to you guys, but even at the paramedic level, to be honest with you, unless that paramedic is a flight paramedic certified or a critical care paramedic technician, we have no business with automatic transportation ventilators, what we call ATVs. This is something that the hospital uses. Yes, it does give us an advantage because it frees up some hands for us, but this is not in your scope. I want you guys to know that they're out there. You guys might see it. You guys have no business touching them. This is 100% completely your medic call, And really, if your service does have a critical care paramedic department, we need to get them there because they are the ones that are trained in these. But you guys can read these over.